So let's make a start. It's 9:15. So my name's Hesham Ziauddin. I am a consultant in the Canyon North Early Intervention Service, and I'm also based at the university a couple of days a week. I've done this introductory lecture a couple of times. Each time I fiddle with it and treat you guys as guinea pigs. This is yet another fiddle, and I've decided to try and keep it less ambitious and just treat this as an introduction to both psychiatry and psychopharmacology. Okay. What I'd like to do is actually just give you a little bit of a conceptual overview about mental illnesses, thinking about them in terms of disorders that affect the brain, and then thinking broadly about the principles of treatment. At the very end, I'll go through some specific details of psychopharmacology. But what I'm hoping to give you is let's go with this. Is, as I said, a conceptual overview about illnesses and their treatment, how exactly we think about treatment, and a very brief overview. So I'll start with this point, but what are mental illnesses? And these are a group of complex heterogeneous disorders that affect higher brain functions, and these higher brain functions include creating a model of the body and the world, memory, enjoyment, emotional reactivity, mental organization, planning, decision-making, motivation, etc. And as we go through the next few slides, I'm going to just spend some time unpacking each of those different bits in bold. But just to outline, when we're talking about these higher brain functions, we are talking about phenomena that are, at least to some significant extent, internal experiences. And one of the big tasks in psychiatry is trying to capture adequately people's internal experiences and interpersonal experiences. So, we'll start with a fairly basic perspective, which is how are mental disorders defined, or how do we make psychiatric diagnoses? And the way that our system is currently set up, and has been for much of its existence, is in terms of descriptive syndromes, i.e. we define disorders or illnesses in terms of constellations of signs and symptoms that co-occur, whose natural history and response to treatment we've mapped out. And pretty much all the diagnostic categories we have essentially are based on a descriptive syndrome with the added specification that that constellation of signs and symptoms either causes subjective distress or impaired functioning. I prefer to think about distress and functioning more in terms of suffering rather than just subjective distress, but we'll unpack that in a bit too. So when it comes to the history taking an examination, I'm not going to go into the details of this, but it's just to emphasize a few particular points. As you know from your practice across various medical specialties, history taking is basically a task in focused data collection, and what you're trying to do is collect pieces of data that allow you to make probabilistic judgments about what the likely cause of this constellation of data points you've collected is. And as you go through the process, some data points will point you towards different directions in terms of other data points you have to explore, and the task is essentially pooling that all together to come to a probabilistic judgment. When we're dealing with phenomena that are essentially internal experiences or interpersonal experiences, one particular point I'd like to emphasize is a distinction that we have in many aspects of our practice, which is between form and content. And I'll just explain this in terms of an example. So when we think about delusional beliefs, we talk about them as abnormal beliefs or unfounded beliefs that are held despite evidence to the contrary. Now, if somebody presents to you with a belief that they have a chip in their nose through which their thoughts are being controlled, it's quite easy to recognize that as an abnormal belief or an unusual belief based purely on its content, i.e. what the belief is about is so odd that it must be abnormal. But if somebody presents to you with a belief that I think my partner is being unfaithful, the content of that belief does not in itself render it abnormal. And that's where you have to look into the form or the shape of that belief. How has that belief come about? What is the evidence upon which it is founded? What is the ongoing confirmatory evidence that it exists? And indeed, how has all this evidence been linked together to come to that belief, right? So when one thinks about delusions of jealousy, the content of the belief may be completely reasonable, it may even be plausible, and our task there is not to decide, is this true or not, to decide whether this is an abnormal belief. We may never be able to get to that. But the way that this belief has come about, does that seem like there is something odd about it? Right? So I've concluded that my partner must be unfaithful because every time the phone rings, they go into the other room. When they come in, they always dust themselves off, and this tells me that they've been seeing somebody else. Now again, each of those individual pieces could be explained away, and again you're looking for collecting data points that help you make some sense of what this particular experience is. So, wonderful, okay. Now, getting back to the point of descriptive syndromes, what I've got here is the descriptive syndrome for major depressive disorder in the DSM-5 as an example. And what you can see are a set of criteria, so depressed mood, anhedonia, weight and appetite changes, sleep disturbance, psychomotor agitation, fatigue, feelings of worthlessness, diminished ability to concentrate, recurrent thoughts of death or suicidality, right? And the way that the criteria operationalize is that you must have at least 5 or more of the following over a 2-week period, one of which must be anhedonia or depressed mood, and they cause significant distress or impairment in functioning. It's just wondering, these are diagnostic criteria, i.e. they're a set of criteria that allow you to make a diagnosis of a condition, and they're operationalized in terms of their reliability, i.e. you can use the criteria to make the same diagnosis by the same person, in the same person, over multiple points of time, or by different people across different people. Very importantly, the diagnostic criteria do not define the disease or the illness that we're talking about. You can see just from this simple operationalization that you could have 2 people who'd satisfy the same diagnosis, but sorry.
Sorry to interrupt. Did you want minutes? Thank you.
The rhythm is ruined, we're never going to get it back.
Sorry.
Okay. But you can have 2 people who could have major depressive disorder with a constellation of symptoms that overlaps very little, right? And this is just to highlight the fact about heterogeneity. And there are multiple levels of heterogeneity that one can think about, but a very straightforward and basic level is the fact that people can have very different presentations of what we would consider to be fundamentally the same disorder. The point about heterogeneity is actually a very important one because it's probably best to think of the disorders that we conceptualize in psychiatry as being families of illnesses that share a certain presentation, share a certain natural history, but inevitably must underneath it all be a set of different illnesses or different diseases that have different pathophysiologies, different courses, different responses to treatment. But as yet, we do not have the ability to specify which those different types are. Under different conditions, we have different subtypes. They're all still to a great extent defined in terms of the nature of the descriptive syndrome. So that's just something to bear in mind, that we're dealing with a very heterogeneous group. There's a lot of overlap across many of these groups, and indeed some of our more recent research suggests that actually there are probably a couple of core domains that underlie a lot of the major disorders that we treat and study. Now, I wanted to get a little bit into this idea of thinking about both subjective suffering or distress and functioning, and how you actually make sense of experiences that are essentially internal, subjective, or interpersonal. There's a criticism that's often levied against psychiatry that actually what we're trying to do is define where the boundaries of normal are. And actually that's not the judgment you're trying to make. What you're trying to make is has someone's experience of themselves in the world changed so significantly that they're now into a territory that we recognize as illness. Now, this is a slight paraphrasing of the original idea by Hippocrates, but the 2 questions that you're always asking when you see someone is, what illness does this person have, and who is the person who has this illness. In a lot of our medical teaching, we do this very well, right? The first question, because that you can teach didactically. You can tell people about what symptoms to ask for, what signs to examine for, how you put them together. Who the person is who has the illness is a vitally important part, but that's something that we don't tend to teach didactically very much, but it's something that most doctors will gather as they go through their training. In psychiatry, we do that a bit more explicitly through aspects of our training, but that's an important thing to remember. Over time, whatever specialty you're in, you'll recognize who's the person with diabetes who's going to really struggle with coming to terms with their illness and managing their illness. Who's the person who's actually going to take a little bit of information, take it all on board, educate themselves, and be a whiz at self-management. Who are the people who are going to struggle more with the uncertainty of a cancer prognosis compared to others? And you will learn to pick these things up. Here we try and sort of get people to think a bit more about it up front and also teach them a little bit about how to do it. That's not what I'm going to do, but I want to just emphasize this in terms of one simple idea, which is the task of modeling minds. And this is the sort of typical empathy question that we teach in there. How would I feel if I was in this person's shoes? And this question essentially relies on two important assumptions. One, that I have a reasonable idea of what it is like to be in this person's shoes, i.e. the perspective from where they are. And two, my mind is an adequate model of their mind, because we do tend to think about other people's minds in terms of the way our own minds operate. And that works reasonably well a lot of the time. It does become rather difficult when you run into minds which are very, very different from yours. And so if the question that you really want to get is, how does this person feel in their shoes? And that requires you to in some way develop a model of the mind of the person you're seeing and accept that actually it may be very, very different from yours. One illustration that I'd give you here, and this again comes from my work in psychosis, is when we think about people who have unusual beliefs, a common line of thought is, if I thought this, I would be doing this. And that's a good illustration of something that relies on both you thinking that you've got a good reading of what it's like to be in that person's position, but also how that particular person's mind works. And that's actually usually a pretty bad guide, right? Because what you want to try and get a sense of is, what does it feel like for this person in their shoes? Again, this isn't necessarily very easy to do, but there are some very basic hacks that you can use. And one is compassion or empathy, which is that I don't quite know what it is like to be in your shoes. I don't quite get what this experience is like, but you're clearly suffering and I'd like to try and help. And that goes a great way. But the other is that you could think about the value of capitalizing the value of the fact that what you're doing is always a within subject examination, right? So you can always figure out how have things changed for this person from what is their baseline. So, we tend to sort of operationalize things and okay, there's somebody's baseline. At some point they cross into a territory that becomes definably illness, and this could be essentially where you could place your diagnostic criteria. You tick enough boxes or tick enough symptoms and you fall into this. But really what you want to get a good estimate of is that, right? You don't want, your aim in treating people is not to get them here, but ideally to get them closer to there. And for that you need to have a sense of how far have things shifted from your baseline. So to give you an example, the symptom of concentration. So you can ask the question about, are you having difficulties with concentration? Yes, I am. But you could quantify that in terms of what difficulties exactly are you having and how is this different from before? If it's a matter, and there are simple ways to quantify it. How long could you have normally sat and worked on one task? How much are you able to do now? What are the difficulties at the moment that stop you from being able to concentrate in that way, right? So that's always very useful, especially when you're trying to make a judgment about, is this degree of impairment or is the severity of this symptom well into the territory of illness. It's also something that's important to bear in mind, especially when you're dealing with people who have very, very different baselines. Now, a useful way to sort of go about this, and this is what I usually prefer to do in clinic when I see new people, is to ask the question, how and when did things start to change? And if you can get people to walk you through that journey from then to the present, then you'll get most of the information you need for your history, for your diagnosis. Of course, when I say walk the person through, that's where your skill and knowledge in asking people about different aspects of that journey, collecting data in a focused way, comes into play. But I generally find this a much more useful way of getting history from people rather than going through lists of, what do you experience? Do you have this? Do you have this? Do you have this? In reality, you're always doing a bit of both. But this is quite a helpful and easy one, and it also allows you, if you do it in a sufficiently detailed way, to get a far more individual picture of someone's illness, and that's helpful in terms of thinking about response to treatment and thinking about relapse and recurrence. And of course, this is the much easier one, which is how is now different from before. So that's a little bit about thinking about how you kind of evaluate these interpersonal experiences. I wanted to come to the other point, which is about, so there's suffering and impairment of functioning. Now, functioning is an important metric in a lot of medicine, particularly so in psychiatry. I have a couple of bugbears about it, which is why I'm subjecting you to this. When you're thinking about functioning, we tend to often think about functioning in this sense. So you are functioning at a particular level and your functioning drops. And that drop in functioning is without a doubt significant. But what I would urge you to think about when you're thinking about functioning is always the cost of functioning. This is a model, it's not a truth, but it's a helpful model in terms of thinking about functioning and cost. So we could think about most of us, or all of us, having some degree of reserve, and you could think about that as emotional, cognitive, physical energy reserve. And it is from that reserve that we meet the cost of day-to-day functioning, right? And if you're thinking about what the elements of that are, just to pick a few of them, so mental multitasking and planning in time, attention and concentration, decision-making, emotional processing and interaction, cognitive control, processing and navigating the world, both in a physical and sensory way. So these are the costs that we would normally incur in the course of day-to-day life. And what starts to happen when people get burnt out, when people develop mental illnesses, when people are dealing with chronic physical illnesses or ongoing severe acute illnesses, is that in the first instance, what happens is that the cost of functioning goes up rather than functioning dropping. And as the cost increases, there are a few things that we commonly experience. And as junior doctors, a lot of this should be fairly familiar to you. But some of the things that occur are you feel increasingly worn out, you feel less efficient, you lose patience, you lose empathy, you lose confidence. We can think about patience and empathy more as a kind of reduced capacity form. You tend to become more irritable, it takes longer to recover. As things go on, you spend your evenings recovering from your days, you spend your weekends recovering from your week, you go in on Monday morning still feeling completely exhausted, and it feels like you can never get enough rest. Life starts to lose its spontaneity, things become more regimented, and you're planning for living within a certain set of contingencies. And if something unexpected happens, you have much less capacity to deal with it. And as things go on, there comes into the picture an anticipatory anxiety or an anticipatory dread on the Sunday evening. Oh God, I've got to go into Monday, I'm not quite sure how I'm going to get through this week. And a shortening of temporal and decision timescales. I can think within this week. I can't look beyond that, because as far as I have enough capacity to get through this week, and then next weekend I'll think about the week after. And over time that shortens. And you also end up making decisions that are less optimal because you're making them over shorter timescales. Now, I don't mean to say that this all takes you into the realm of illness, but these are things that happen as the cost starts going up. And when we get to the point where functioning drops, it's usually at a point where you can no longer actually manage the costs of functioning. This is unfortunately the point where we tend to pick up people very often in secondary care services, and that's a necessity of funding and so on. But this is always worth remembering that actually by the time people's functioning has dropped, there's a lot of costs that they've already incurred. And you may find that people who tend to be high functioning at baseline, or people who work in systems where there is very little scope for not being able to function, and I often think of doctors and academics as two good example groups. You can just keep functioning till the point where you no longer can, right? And that could be seen as, okay, this is a sudden dramatic deterioration, but very often the costs have been accumulating for quite a while. So that's something to bear in mind, and especially when you see people in clinic, in any specialty, who seem okay, to ask the question, how much is it costing you to seem this okay? A complaint we often get from people who've been to chronic physical health illnesses is that I turn up and they say, well, you look fine, so you must be fine, without realizing that it's taken me 5 hours to get ready to come to this meeting today. And under the pressure of a social interaction like this, I have pushed myself to look as optimal as I can. But that isn't telling the story. The story is really, what is the cost that you've had to endure to function at this level? When you're thinking about more chronic illnesses, then this works reasonably well in the acute setting. If you're dealing with an ongoing illness of any kind, it's not possible to maintain the costs indefinitely, and very often what people have to do is end up making some kind of change, limiting their lives. And there, when you're seeing people who've been ill for a long while and seem to be functioning, the question to ask is, what have you had to give up to be able to function at this level? Okay, so now, so at this point, just to emphasize, the diagnostic criteria are criteria that allow you to make the diagnosis. You can and you should think about people's baseline. Always think about the cost of functioning. And this is a bit I haven't touched upon yet, but it's worth remembering that there are broadly two purposes of a diagnosis. One, a diagnosis should help understanding of the person and what they're suffering with, both for the person, for people in their lives, their near and dear ones, and for you and the team that are looking after them. Now that is an active purpose, in the sense that you have to work to make that happen. Giving a diagnosis to someone or putting a diagnosis on paper doesn't necessarily do that. And the other is that it should help guide treatment. And in clinic, these are broadly the two purposes of a diagnosis. There's of course another purpose that's outside the broader context of healthcare, which is in terms of people getting benefits and adjustments and so on, where a lot of those systems are diagnosis based. Okay. So this is one of the 4 bits that I have in Italian, which is why disorders. And really this is a conceptualization of syndromes, disorders, diseases, where psychiatric illnesses are in the category of disorders, broadly speaking, because of the issue of etiology and etiopathogenesis, because we don't have conditions where we have very clear-cut etiologies or etiopathogenesis. Of course, this idea of having very precise etiologies and etiopathogenesis comes from rather specific aspects of medicine, and infectious diseases is probably the best example of this, but increasingly we're now aware of complex multifactorial illnesses that don't have clearly defined pathoetiologies, and that's something we're a lot more comfortable with in many other areas of medicine. This is a problem we struggle with several camps within psychiatry. But it's just worth bearing in mind that most of the higher brain functions we're talking about are not simple functions. They're complex functions that are carried out by distributed systems. So the idea of thinking about a lesion or a specific pathology that knocks out an integrated brain function doesn't make very much sense. On a group level, we can find some variations in pathology, changes in grey matter, changes in white matter connectivity, but they tend to be distributed, and as yet we can't determine them at the individual level, right? So a group of people with depression or a group of people with a diagnosis of schizophrenia can have been consistently shown to have specific brain abnormalities. None of them are at the level where you could use it as a diagnostic test within an individual. So it's perhaps best to think about mental illnesses as dysfunctions of brain networks that affect higher brain functions. And I'm not going to dwell upon this, but this is an idea that's taken maybe the last 10 years or so of thinking about brain networks. And what these different colors highlight are different modules within the brain, and each of these dots represents a hub point where you have a great many connections. And there's been a lot of work in this area which has looked at the fact that actually what mental illnesses seem to do is particularly affect the hub areas where you have lots of connectivity, lots of information being passed. Now that could be because something changes in the functional information passing, it could be because there is actually a structural change, or it could be both. But as yet we're not at a point where we can say, well, this is definitely what's happening in this condition or this condition in this individual. So the last bit in there was about complexity, right? And you've probably come across the term the biopsychosocial model, which is been the dominant model in psychiatry for several decades. And what that essentially postulates is that there are these three elements that you do have to take into account. And what the task really is kind of determining in the individual person what the various aspects of these elements are and how much they contribute. I like to think of it in this particular framework, which I find to be more helpful, and that's to think about us in terms of being brains embodied in bodies, embedded in environments. And I've put a little blob in the middle for the mind. I'm not going to get into a whole area of philosophy, but I'm going to go with the definition that Chris Frith, who's one of our eminent neuroscientists, has come up with, which is our mind is essentially our conscious experience of ourselves that our brain creates. The bulk of what the brain does not come up to conscious experience, which is a good thing. You don't want to be thinking about how you move your muscles to walk, you just want to walk, right? But the important thing is that all of these elements are critical when you're thinking about individuals or you're thinking about illness, and there are interactions across them all. We've suffered along the way from various forms of dualism. So there's been a brain-body dualism, that these are two separate things, a mind-body dualism, and then also a brain-mind dualism, that somehow these are all separate things that ought to be examined in their own right, whereas in truth they're all integrated, right? And I don't present this as a sort of everything ultimately comes down to the brain. Well, in a sense it sort of does, but actually there's no such thing as an isolated brain. Brains exist in bodies and environments, and of course some of the most complex things in that environment we encounter are other brains and other bodies. Okay, at the bottom here I've put time, because you can think about this as a snapshot in time, but really what you're looking at is a cumulative history. And the history of our experience is essentially contained within our brain and the environment that we create around ourselves. So this is Chris Frith's book, if you want to know a little bit more. It's a bit old now, but still a lovely read. Now, I introduced this because I wanted to get his idea of thinking about the brain and what the brain does. And I want to just introduce you to the idea that what the brain fundamentally is a predictive organ. The task of the brain is to create a model of the body and the world that it inhabits, and it does this in a predictive fashion, i.e. it's not assimilating information continuously and then pulling that information together. It's making predictions about the information coming into it, and it's updating those predictions in the light of new information or in the light of mismatches, technically, between what it predicted and what actually happened. So this is a nice illustration of that. I don't know if any of you have seen this before. This is a picture of a woman kissing a horse. It's a bit difficult to make out, and I'm going to give you a little bit of help. Right? Don't feel bad if you didn't see the woman kissing the horse, or if you still don't. I'll give you... This is just meant to illustrate a very simple principle, that from the first and second time, or the second and third time you've seen this picture, nothing has fundamentally changed in this picture. This is a set of black and white patches. What's allowing you to make sense of it is that you now have some prior information from the color photograph that allows you to disambiguate this. And that is just a very powerful illustration of how the brain works in this predictive way. Okay. Well, let's see if this works. This is just an illustration of essentially how the task the brain faces is always having to make sense of information that's ambiguous, right? Now what you're seeing here is an arch supported on 4 pillars, but the physics of that figure seem completely implausible. Now as it rotates around, you can see why the figure has that sort of physics. But the point to illustrate is that what you saw at the beginning could equally have been produced by an arch supported on 4 pillars, or by a figure like this, right? It's just a very nice illustration of the fact that sensory information that comes to us is fundamentally noisy and ambiguous, and a big task that the brain has to do is essentially make sense of it and infer what is the thing that could be out there that led to me getting this pattern of information or this experience. This is another powerful illustration. Many of you have probably seen this. This is the hollow mask illusion. Now, it may not necessarily happen for everyone, so don't be worried, but essentially it's a hollow Charlie Chaplin mask, and the feeling that a lot of people get when they see it is when the hollow side comes forward, it seems like it pops out. Even though you know it's concave, it pops out. And the explanation in this predictive model is that faces pop out. Faces are biologically highly salient stimuli, and by their nature, they don't tend to cave in. So the moment that that information is put together to form a face, it immediately pops out, because that is the nature of faces. For people who experience the illusion, even knowing that it is a hollow mask doesn't allow you to override it. The face still seems to pop out. Okay, so just to sort of quickly sum up, so if what the brain is doing is creating a model of the body and the world, it is constantly doing this in this iterative fashion, making predictions, updating predictions in the light of mismatches. And this is just a very simple illustration of how exactly we think that works. And this seems to be a fundamental part of the way the nervous system is organized, that what you have coming in from the lower levels of the neural hierarchy, or at the very lowest level, you have sensory input. But from that point onwards, each level of the hierarchy has a prediction about what information is coming into it. So it predicts what it can, it passes on what it can't predict. And the next level deals with what's left, and the level after that with what's left. So to give you an example, in the visual system, as you know, you've got various kinds of feature detectors, line detectors, edge detectors, contours, color, and so on. And there are different levels that deal with each bit of that and pass the rest on. What's passed on is called the prediction error, i.e. the mismatch between what that level predicted and what came into it. So whatever it could predict, it dealt with, the leftover is passed on. And this prediction error is a very important learning signal in the brain. So the higher level passes on predictions to each level below, and each level passes on a prediction error to the level above. So I'm just going to illustrate this with psychosis, which is probably the condition that best sort of exemplifies a disturbance in this very fundamental brain function. And psychosis is probably best thought about as a fundamental alteration in the model of the world and the body. and there are multiple ways in which that's affected. And in this cartoon, what I really want to represent is that there is a lot that happens in psychosis. People's experience of the world fundamentally changes. We've got a diagnostic threshold that picks up the most salient or the most striking aspects of that altered topography, and that allows us to make reliable diagnoses. But it's just to emphasize that underneath that there is a lot else that has changed, and that's to just highlight that point of diagnostic criteria allow you to make diagnoses. They don't actually entirely define the illness. Okay, I'm going to skip over, well, just very briefly thinking about this idea when you're taking a history, if you're trying to understand someone's illness, when you're trying to make a diagnosis of a condition like schizophrenia, you can look at a baseline when things were different to when things have changed. But you can also encounter people who have very, very different models of the world that may seem completely alien to a lot of us. Two groups that we commonly encounter in psychiatry are people with this very controversial diagnosis of borderline personality disorder and the autistic spectrum disorders, whose experience of the world is very, very different. And if you take a cross-section, you could come away thinking that a lot of what this person experiences is clearly abnormal or pathological. And the key thing to look at is actually, is this a change from the way it used to be, or is this how the world has always been for you? Okay, right, so I won't dwell on this, but let's go on to thinking about treatment. Okay, so some important considerations to bear in mind. Mental illnesses often involve long periods of illnesses. They're often recurrent episodes of illness. There are attendant effects on life and quality of life and functioning. They involve considerable cost for the individual, and they reshape people's lives and personalities. Okay? So when you're thinking about the aim of treatment, the overall aim of treatment is to help people recover and rebuild their lives. Right? That is the overarching goal. There are several objectives that would fall under achieving that goal. So one would be optimizing medication, helping with past trauma, learning skills that people have missed out on, addressing self-esteem, self-image, helping and supporting relationships, different forms of psychological therapy, modeling, caring, and being cared for. That's not an exhaustive list. That's just to say that there are several things that one would do to help a person towards that ultimate aim, which is, can we help you recover and rebuild, sometimes build your lives, especially if you're talking about people who've become ill at a very early stage in their lives and have missed out on lots of key developmental experiences. And it's important to keep this in mind because very often these things can become aims, right? That what we're trying to do is get your medication right, and that's our goal. Or what I'm trying to do is come off medication, and that's my goal. And it's just worth reminding people all the time and stating that this is what the goal is, this is what we're trying to do. So, in the last few minutes, we're going to get into psychopharmacology. So we've been talking about phenomena that we largely study at this level, right, where we're looking at clinical phenotypes. For different conditions, we may be venturing into this level, thinking specifically about cognition, but that's largely the domain we operate in clinically. But when it comes to our treatments, we're using treatments that largely work at that level, at the neuronal or the brain network level. And most of the treatments we use are serotonergic, noradrenergic, or dopaminergic. And what all these neurotransmitters share is that they're all neuromodulatory neurotransmitters, i.e. they modulate the function of other neurons or other brain networks. They're not primary transmitters like GABA or glutamate. So what our treatments are essentially doing is modulating neurons and brain networks to try and produce a change over here. So one illustration or one example is to think about what antipsychotics do in psychosis, right? So I told you about this particular model of information passing in the brain. The prediction error signal is a dopaminergic signal, and it carries a few different pieces of information. One, whether it's present or not, tells you whether there's a prediction error, whether there's something that you've missed or something unexpected that's happened. The magnitude, i.e. how much of a prediction error, is conveyed by the level of the dopamine firing, but also its precision, i.e. how or what the standard deviation of that signal is. So if you're in a very noisy environment where unexpected things happen or expected things fail to happen, you may get a lot of prediction errors. But if it's a very noisy environment, you shouldn't really be adapting to each prediction error. You should be thinking about the prediction error in terms of how precise it is. In psychosis, one of the final common pathways is that you have excess dopamine release presynaptically. And what that seems to do is essentially very majorly mess up this prediction error signal. You could have prediction errors occurring where they shouldn't. They could occur with inappropriate magnitude. They could occur with inappropriate precision. And when that gets passed up the neural hierarchy, ultimately at some level it means that the model of the world has to change to accommodate this altered prediction error. The drugs we use are antipsychotics, and what they do are they block dopamine postsynaptically. They can't do anything about the excessive presynaptic release, but you block the postsynaptic effects to essentially normalize this prediction error signaling so that the brain's previous model gets a chance to reassert itself over time. Okay, so last couple of minutes I'm going to just talk about the question of how you choose psychotropic medication. This is what I generally tend to follow. I think it works as a reasonable rule of thumb. The first question is a medication tolerable enough for people to have a reasonable trial? If it's not, then you probably ought to change quickly. Is it effective? And if it's effective, then is it effective enough? Right? What you're trying to do is essentially try and get people as close as possible to their baseline. That depends a lot, of course, on where you're seeing someone in the trajectory of their illness. I work in a first episode service where I have the privilege of actually seeing people very early, where it's reasonable to think about getting them back to a pre-morbid baseline. If you're treating somebody who's been ill for 20 years, then it's a different picture and a different kind of baseline that you're trying to get back to. But the question still remains, the treatment that you're giving them, is it effective enough? And you have to conclude that sometimes you have to conclude that this is as good as it gets, but only after a period of trial. And finally, is it tolerable for longer term treatment? When you're dealing with long-term illnesses that do have recurrence in their very nature, you do want to find treatment for people that they could take for the long term. Even if they stop it at some point, it was tolerable enough for them to go back to. And it's worth thinking about several factors that will come up later on in people's lives, even if they're not relevant to this point in time. And one of the things I particularly emphasize is when you're seeing women in the reproductive age group, be thinking about treatments that they could more easily continue to take during pregnancy, during breastfeeding. Okay, so this is going to be a very brief run-through of psychotropic medications. Having done these sessions before, I think most of you are at a point where you're not generally making key prescribing decisions. And so what I thought I'd provide is rather than how do you prescribe, how do you go about, is a broad sense of, look, these are the drugs that we use, these are the things to bear in mind. What you're always balancing is the challenge between efficacy and tolerability, and it's important to remember that a lot of the drugs we use do have side effects that are quite distressing and don't necessarily go away during the course of treatment. And some particular things to bear in mind are weight gain, sexual dysfunction, menstrual disturbances, and emotional blunting. When it comes to treating the common mental illnesses, depression, anxiety, and OCD, we tend to use the SSRIs like fluoxetine and sertraline as first-line treatments. When you do a condition like OCD, the evidence is actually far more supportive of very high-dose treatment. For psychosis, this is, again, largely from my practice. I tend to go for these two drugs as first line, aripiprazole and quetiapine, mainly because their side effect profiles generally tend to be better, especially when you think about longer term treatment. For bipolar disorder, we use mood stabilizers, lithium and valproate being the main ones, and we also use antipsychotics, which seem to work as mood stabilizers for this condition. There's a difficult aspect of bipolar, which is bipolar depression, that you can't treat with antidepressants because the efficacy isn't great and the risk of switching and longer-term mood instability is high. So for bipolar depression, the evidence at the moment favors quetiapine, lamotrigine, and lurasidone. And what I would suggest in terms of best resources, if you're ever looking up, if you ever want to look up drug choice and drug treatment, I'd recommend the British Association of Psychopharmacology guidelines. They're free and they're available on their websites, and they're very comprehensive documents. The Maudsley guidelines are also very helpful. They're not free, though you can get free copies on the internet. And then the NICE guidelines. But I definitely favor the first two over the NICE guidelines because they give you a lot more information. They're a lot more nuanced. Okay. I think we're probably out of time. Oh, 5 minutes. Okay. So
Questions as well.
questions as well. Okay. Well, what I might do is I can pass these slides on to you and you can circulate them, and yeah, these are all just various basic baseline measurements and monitoring during different kinds of treatments. Rather than whiz through them, I'll give you guys the slides so you'll have them for it. I'll probably just end with these pointers. In general, don't stop medications suddenly. There are some medications you've got to be particularly mindful about. Clozapine is one. And if you're working in a general hospital and you come across somebody who is on clozapine, or you're sending somebody to the general hospital and they're on clozapine, remember that general hospitals don't usually stock clozapine. So you've got to send people with their supplies, or you've got to make arrangements with a local psychiatric hospital for that. Always check prescriptions so that you maintain people's continuity. It's a thing that we experience currently, where people get one prescription and then it's not updated for the next prescription, so they undergo unexpected dose changes or treatment cessations. And always think about interactions with other medications. So a common one to bear in mind is omeprazole, which is a CYP2C inhibitor, will affect the levels of a lot of the drugs that we use because they're essentially metabolized by CYP2. And a common one is with antidepressants, fluoxetine, sertraline. All their levels are increased by omeprazole. I'll forget the methadone and buprenorphine. But a final point about side effects. Anticipate side effects and actively inquire for side effects, because people may not necessarily tell you. And we often ask, are you having any problems? And people say no. There are some particular problems that people very rarely volunteer to you. Sexual dysfunction, menstrual changes are things that you often have to specifically ask about. Think pretty carefully about your choice of drug and change drugs quickly rather than letting people linger on them. For both antidepressants and antipsychotics, we've had this idea around for a long while that it takes 4 to 6 weeks to tell if a drug works. That isn't really true. Certainly, if you can get the level of detail for both these groups of drugs, you see effects within the first 24 hours. Clinically, that may be a bit hard to discern, but what's perhaps a more useful guide is that with both antidepressants and antipsychotics, the steepest slope of response is in the first 2 weeks, right? So if somebody is responding, the degree of response will be highest at that point. That's, of course, subject to you getting the dose optimization done, right? But if people aren't responding, change quickly, or if people can't tolerate, change quickly. Okay, so I'll stop there. Thank you very much.